Yeah, so thanks, David. So David is a public health programme manager at Glasgow Centre for Population Health. He leads on a wide range of research programmes which ultimately examine the nature and causes of and solutions to health inequalities. That includes a lot of work on Glasgow and Scotland's health, and also deindustrialisation and health across European regions. So we're really excited to have him sharing a lot of that work with us today. A bit about GCPH itself. It's a research institute funded by the Scottish Government, but it operates as a partnership between NHS, Greater Glasgow and Clyde, Glasgow City Council and the University of Glasgow. So since 2004, it has sought to generate new insights and evidence, support new approaches and inform and influence action to improve health and tackle inequalities. And I think we're going to put in the chat the link to the website, but it's a brilliant website for anyone who wants to look at that in more info. There's loads of infographics and brilliant resources on there, so please do check that out. Right, thanks very much, David. Over to you then.
Okay, well, thanks Fiona, thanks for the nice introduction and more generally for the invitation. Thanks to all of you for tuning in. I can hear you tuning in every few seconds because it goes beep beep. There's another one. Most of you, I think, if not all of you, are tuning in from England, and as Fiona said, I'm here in Glasgow, and so I'm going to talk mainly about Scotland, which I suppose begs the question of to what extent that's remotely interesting to you. So just to reassure you, although I'm going to talk about Scotland, I'm going to explicitly do that in reference to other parts of the UK and also other parts of Europe. And the lessons from the stuff I'm going to talk about apply equally across the UK, not just in Scotland. So hopefully that will maintain your interest and keep you sort of connected to the presentation, both metaphorically and literally in the sense of teams. So specifically today, what I'll do is I'll give you a little bit of background around health and health inequalities in Scotland. Again, in case you think that's not going to be of any interest, I'll do it very briefly and, as I said, with reference to elsewhere. And then having done that, I want to then talk about understanding the importance of political and economic decisions, what gets referred to as the political economy, in understanding those trends and understanding other trends across the UK. And I could do that in a number of ways, I suppose. One way would be to do it in a sort of theoretical fashion if I was presenting to students, and I might show, for example, models of health determinants, which would have sort of health behaviours being governed by the socioeconomic environment, being then governed and influenced by political decisions. And I think that would be quite an informative approach, but also quite a dull one. So rather than do that, what I thought I'd do is give you some kind of more practical examples in terms of 4 case studies from work that we've done over the years, which make the point about the importance of these political and economic decisions. I have to warn you that these case studies get progressively more depressing the longer we go through the slides. So you may get to a point where you're thinking, geez, this is quite dark. The only thing I have to counter that is a rather pathetic thing that I'll promise to show you something vaguely amusing at the end in terms of a funny picture. It is a desperate attempt to lighten the mood, but you can at least bear that in mind if you find yourself quite depressed as we go through. I think, as Fiona said, before you all joined, I'll speak for about 35 minutes, maybe not quite as much as that, maybe about half an hour from now, and that should leave plenty of time for questions, discussion, chat and all the rest. So I hope that sounds okay. We're sort of back in COVID times here and that I'm presenting into the void, so I can't really see anybody, but I'm assuming you're all nodding vigorously and very happy with this general approach. So just in terms of background to all this, I used to, when presenting to students, I used to always ask them what they thought about if they thought of Scotland's health. I stopped doing it for a number of reasons, including the fact that I got a bit tired of debating the myth of the deep-fried Mars bar. For anyone interested, nobody eats deep-fried Mars bars up here. The only people that do so are journalists who write about them, and then tourists who've read what journalists have written about them. So an alternative approach to asking that question is just to say that if you work in public health and you think about Scotland's health, one of the things that pops into your head is headlines like this: the sick man of Europe. This is a frequently used headline in the Scottish media, as you can see. And one of the interesting things about this headline, I think, is that unlike a lot of what you read in the Scottish media, especially from open inverted commas newspapers, close inverted commas like this one, is that it is actually true in the sense that if you look at some sort of summary measure of population health, like life expectancy, Then Scotland does lag behind every other Western European country, and that's true both for men and for women, and you're probably already familiar with that. What you may or may not be quite so familiar with is part of the explanation lies with a much slower rate of improvement over time. So this next chart shows long-term trends in male and female life expectancy for about 19 different Western European countries. So every red line here is England, Spain, Germany, whatever. And these trends go back to the middle of the 19th century and are more or less up to the present day, up to just the pre-COVID period, up to the end of 2019. If I just highlight Scotland's trajectory, there's a couple of points worth making. As the slide said a second ago, Scotland has not always been this so-called sick man of Europe. From about the middle of the 19th to about the middle of the 20th century, Scotland was kind of in the middle of the pack of all these countries. But what's happened over the last 6 decades or so is that although things have continued to improve generally, they've improved much more slowly than elsewhere, meaning that by the end of the period, we are in this position of having much lower life expectancy. You can see quite a dramatic change of trend in the last 10 years there, and I'm going to pick up on that in one of the case studies later on. The other point to note is that divergence of Scotland from other countries has been particularly acute since about the late 1970s, or to be much more politically accurate, from 1979. And as many of you will be familiar, that period from 1979 has been one in which Scotland, but also the UK generally, has become quite a different society, a much more unequal society. These are trends in income inequality, the gap in income between rich and poor, which increased massively over that time. And because of the very clear, pronounced links between income and health, we've seen a corresponding widening of health inequalities over that time too. And that's all relevant because part of the explanation for low comparative levels of life expectancy in Scotland is that we have much wider health inequalities than elsewhere. And importantly, that pulls down the overall average. I could throw all sorts of stats at you and examples at you just to make this case. Don't worry about the detail. This is one particular study from a few years ago, just showing that gap in health terms between rich and poor is much wider here than elsewhere. And you've all seen stats like this, showing a kind of scandalous gap of whatever that is, 13 years in life expectancy across levels of deprivation. Obviously, you could show something very similar for England, but the point is that the gap here is a bit wider. And I'm in Glasgow, and in Glasgow you can show all sorts of horrible things like this. What's that? An 18-year gap in life expectancy between a couple of neighbourhoods that are only actually a couple of miles apart. Again, given the fundamental unequal nature of UK society, you could show something similar in any English city. But the point is that if you measured it on a like-for-like basis, the gap is again bigger in Glasgow. And indeed, the scale of inequalities are such that they featured in this now quite out of date, but at the time quite a kind of landmark publication from the World Health Organization. I think this was about 2008, which at the time highlighted a 28-year gap in male life expectancy, again between a couple of neighbourhoods that are only actually a few miles apart. Now, there's a couple of things to say about this table. The first is these data are massively out of date, so please don't go quoting them. And the other thing is this is arguably one of the most profoundly stupid tables ever put in a report, because what they're doing obviously is comparing life expectancy in small neighbourhoods of about 3,000 or 4,000 people with entire countries of, what's America, 500 million people, India 1.4 billion people. It kind of makes no sense whatsoever. In the WHO's defence, though, what they were doing was trying to illustrate the scale of inequalities both between countries but also within countries. And I think it's very telling that they used data not just from Scotland but from Glasgow to do the latter. And there's a famous quote, a lot of you will be familiar with this report, but there's a famous quote in it, if you remember, which says that it does not have to be this way and it's not right that it should be like this. Social injustice is killing people on a grand scale. Killing people on a grand scale. It's a very powerful quote. But there was also a retort from a guy called Vicente Navarro at the time. He's a political economist, Spanish, but based in America. Quite elderly, but still working. And he retorted when that report came out by saying it's not inequalities that kill people, as the report states. It is those who are responsible for these inequalities that kill people. So in other words, it's the people that make the political and economic decisions that create this situation. And I think that's quite a neat introduction to this whole topic of the political determinants of health and health inequalities that I want to focus on for the rest of the talk. And as I said at the beginning, I'm going to use 4 case studies from what we've done over the years just to try and kind of hammer home this point. These were all quite big projects. There's quite a lot of detail in them, so I'm going to romp through them quite quickly, okay, not linger in any detail, just to give you a kind of overall flavour. So the first of the 4 is some work that's actually quite a number of years ago, probably about the same time that WHO report was coming out. And this was work in which we were comparing health and its determinants across different parts of post-industrial Europe. And the reason for doing that should hopefully become apparent. As introduction to that, this is a different picture of inequalities in Scotland, not by neighbourhood or level of deprivation, but by the 32 local authority areas, local government areas. You see them there on your map. And just like in England or lots and lots of countries, the areas with the poorest health are those which were previously industrial, but which have since suffered from the profound effects of deindustrialisation, the loss of employment, increased levels of poverty, etc. In Scotland's case, just about all of these, apart from Dundee, lie in what gets referred to as the West Central Belt, which I can show you on this map. And in this project, we were comparing health and its determinants in that West Central Scotland area with other parts of both the UK and Western and Eastern Europe, which had all experienced broadly similar levels of deindustrialisation. And the aim here was to make more kind of like-for-like comparisons than you get compared with, say, country-level comparisons. And what those analyses showed, ironically, quite similar to some of the country level comparisons, was that at that time health in Scotland or the Scottish area was improving. This is female life expectancy, just as one example. But again, it lagged behind these other comparably deindustrialised Western European areas, and actually had been overtaken by some of the Eastern European areas as well. And then trying to unpick the kind of reasons for that, we did all the sorts of the usual quantitative analysis in terms of, data collecting, number crunching, tree killing, killed ridiculous numbers of trees. It's kind of unforgivable looking back now. But actually, and if there's any qualitative researchers among you, despite all that quantitative work, most of the kind of more useful insights actually came from more qualitative kind of policy-based work. But in its entirety, what all the work showed was that the main reasons for differences in health across all these many different areas of Europe were just basically all about politics. They were all about political decisions. So from the quantitative and the number crunching, we showed, for example, that income inequalities were much wider in the Scottish area alongside the other UK areas. And again, that's relevant because of the link with health. So income inequalities drives wider health inequalities. But more broadly, there was just evidence of better political decision making in all these different places compared to what happened in the UK, and particularly what happened in the Scottish area. As I said, I'm not going to bore you with the details, but I'll just give you a couple of insights. So, for example, in the French area, which was an ex-mining area called Nord-Pas-de-Calais, there was evidence that it saw the threat of deindustrialisation earlier, and it diversified more quickly into new technologies, therefore protecting employment, protecting against poverty, and that was also achieved through mitigation in terms of better levels of social security. The latter also happened in the Polish area we were looking at, where there was also much more significant state investment, better redevelopment. There was also mitigation in terms of the Czech area, but they also managed to retain a bit more industry and again, retain a bit more employment, protect people's incomes. And in the German area we were looking at, again, there was better investment, better planning, and also aspects of mitigation to protect the most vulnerable populations. So it wasn't that there was one single thing that happened that was the same in all these areas, but there was one underlying theme, which was, as I've said, it was all political. So that's one very, very quick example. The second example follows on quite nicely from that, I think, and that's about why we have much higher levels of mortality in this city I'm in today, Glasgow, compared to broadly similar places like Liverpool and Manchester. And this is what gets referred to in the media, open brackets, entirely unhelpfully, pointlessly, meaninglessly, close brackets, as the Glasgow effect. And I'll come on to that title just in a wee second. But just to introduce this by going back to this chart of life expectancy across the 32 local authority areas, you'll probably have noticed that the area, and you probably knew this anyway, with the lowest life expectancy is indeed Glasgow. There's a really, really important point to make here. which is that the principal reason of this, there's no mystery about it, is just about poverty. As you will all know, poverty is the main driver of poor health anywhere, be that in Glasgow, be that in England, be that, you know, across the world. And just to show that and labour the point a little bit, if we just put that chart up there, the top of your screen, and label it life expectancy, and then just bring in a chart of some kind of measure of poverty. This is area deprivation. You see that one is a mirror image of the other. Where you get high levels of poverty, you get poor health, you get low life expectancy. And to labour the point a little bit more and move again beyond Scotland to the rest of the UK, if you plot some kind of measure of poverty on one axis and plot how long people live on average on the other, and throw in some of the main UK towns and cities, you see the tragic truth of the matter that the greater the level of poverty in society, the younger on average people will die. The issue for Glasgow is that it's always been a bit of an outlier, and we spent a lot of time and a lot of research trying to unpick why Glasgow's health outcomes were so different than other kind of broadly similar places like Liverpool and Manchester. And the result of all that was published in the world's longest report, which I don't recommend you read. The summaries are available. And the answer, you'll be unsurprised to know, was it was all about politics. In this case, it was about a whole series of historical political factors which had placed much greater disadvantage on Glasgow in comparison to places like Liverpool and Manchester. This is about a, 40, 50 minute presentation on its own. So again, I'll only skim the detail here for you. But in essence, lots of things contributed to this. Lots of different historical factors placed greater disadvantage on Glasgow. They included things like worse living conditions to start with. And this is obviously relevant to adult health then, but also still adult health today. And these have political influences. Entirely linked to that, changes made by local government in the post-war decades had a much more detrimental effect on Glasgow than the comparator cities the evidence showed. And that relates to lots of different things. For example, the scale of slum clearance and demolition, which was much, much greater in Glasgow and is relevant because of the way it broke up existing communities in the city. It relates to building really, really, really poor quality peripheral housing estates. Again, this was done across Britain, but the evidence showed on a much larger scale in Glasgow, housing and affecting a lot more people in absolute and proportionate terms. It also related to building an awful lot more very high multi-storey flats, relevant because of the research evidence linking this type of high-rise living to negative impacts on mental health. There are clear, profound evidence links between poor mental health and poor physical health. And on top of all that and lots more, there was just evidence that they just invested less money at key points in time in actually, repairing and maintaining these properties, looking after the houses that people were living in. So when you compare the cities of Glasgow, Liverpool and Manchester over long periods of time, although levels of income-based, income-defined poverty were always very similar, people in Glasgow were just living in worse conditions. And that's obviously highly relevant to health. On top of all that, there's a whole story about how the UK government, or to be more accurate, the Scottish office, which was responsible for implementing UK government policy at the time, how they also acted in those post-war decades. And this also had a massively detrimental effect. I don't have time to go into the detail, but evidence emerged from this work from government archives that they basically gave up on Glasgow because of the state it was in. So they officially designated it to be a declining city, and all economic investment was to be made away from the city. And as part of that, there was a socially selective movement of people away from the city, and that clearly had a major impact on the composition of the remaining population. On top of all that and lots more, by the time we got to the 1980s, which was, as I referred to earlier, a period of increased poverty and widening inequalities, there was evidence that in the other cities, in Manchester and Liverpool, they just did things a little bit better. And there was much less done in Glasgow in terms of looking after its poorest and most vulnerable populations. So again, I'm not going into all the detail, it would take too long, and you wouldn't thank me for it anyway. But what emerged from it was all about political decisions. And what that also means, which I'm always keen to talk about, is that there's basically no such thing as a Glasgow effect. There's nothing different about the people in Glasgow. It's just another example of political effects on health, which is what I'm talking about today. And indeed, I think that was the more or less the title of the paper a couple of years ago we published when we updated these analysis of poverty and mortality in Glasgow, Liverpool and Manchester. As a quick aside, before I go into the third case study, when we published that report in 2016, I had the unbridled joy of speaking to lots of journalists, and I explained to lots of journalists how this term Glasgow effect was pretty much meaningless, and asked them not to use it in the coverage of the report. And it was really, really heartwarming to see how they responded by not using it, apart from, you know, in every bit of coverage that there was. But hey ho, mustn't be bitter, life's too short and all that. Okay, the third of the 4 case studies, and you'll see I'm romping through these really quickly, but there's a reason for that. I don't want to dwell on any of the individual details. The third of the case studies brings some of these kind of health and mortality trends much more up to date. And for the background to this, I need you to travel back in your mind, if you can, to just before the pandemic, when there were a number of headlines appearing about, quote, a stalling of improvement of life expectancy. A stalling of improvement, and this was both in Scotland and across the UK. I'm reasonably confident in saying that for most people who saw those headlines, they would have had absolutely no idea what that meant, a stalling of improvement. And even if they read the article and the details in it, which were basically saying that life expectancy was no longer improving as fast as it once was, they probably thought, who gives a shit? Does this really matter? What does that mean? But if you're working in public health, obviously, and a lot of people I hope are nodding their heads here, this was ringing all sorts of alarm bells for the very simple reason that it shouldn't happen. In a wealthy society, be that Scotland, be that the UK, life expectancy should still have been going up, or conversely, because it's based on exactly the same data, mortality rates should still be coming down. So that caused lots of people, including ourselves, to look into this in a bit of detail. And what emerged from the data is like truly, truly, truly concerning, and I would argue pretty much unprecedented. So we'll start with England first of all. I'm going to show you trends in female mortality rates, but the picture for males is the same. And this shows long-term improvement in mortality rates for females in England back to the 1980s. I could actually track this back decades and decades and decades beyond that as well. But then round about the early 2010s, we see this so-called stalling of improvement, this kind of levelling off, this kind of slowdown in improvement. What's really important about this is it's not about those living in the least deprived areas. These are the 20% least deprived neighbourhoods of England. There is a slight change in the trend, but importantly, mortality rates are still coming down. But it's very much about those living in the most deprived areas where barely believably mortality rates stopped coming down and actually started to go up. Now, again, at the risk of labouring the point, in a wealthy country like England, this just shouldn't happen. And also, this isn't the 1% or the 2% most deprived parts of England, people on the periphery, if you like. This is a fifth of the whole population. The picture in Scotland on a slightly different scale, and hold on a second just while I shut the window, because the weather's still quite nice up here, and there's people now cutting the grass. Hold on a sec. There we go. On a slightly different scale, because mortality rates are a wee bit higher in Scotland, it's exactly the same. So increasing death rates among the most deprived 20%. If you look in a bit more detail, so looking at, for example, premature mortality rates among females in Scotland, you see really sharply increasing mortality rates among the most deprived 20% of neighbourhoods. If you look at those same data for this city, Glasgow, you see a dramatic reversal of sharply falling mortality trends among the most deprived group. And I'll come back very briefly to this chart just in a wee second. For those of you who know Edinburgh, you'd know that Edinburgh is a fabulously wealthy city. So why have we got increasing death rates among the 20% most deprived areas of that city for men of all ages? And if you look at male premature mortality, in Dundee, you see absolutely dramatic changes in that city. Hold on 2 seconds. Okay, sorry about that. Now, all these changes, a lot of you will be aware of, coincided with the implementation of the UK government's austerity programme, which sought to cut astonishing amounts of money from public spending generally, and including, obviously, vitally important public services, but also, and more perniciously, cut tens and tens and tens of billions of pounds from social security. As you all know, social security is a safety net for those living in difficult circumstances. If you take that safety net away, what happens? Well, what the data seem to show that people die, and they die younger, and they die in increasing numbers. And this is all can become quite emotive. So we have to be very clear in public health, is there evidence to support this? But I would argue now there's an absolute wealth of evidence to absolutely make this case. And the evidence comes, I think, in three different layers. So first of all, and slightly more abstractly, there's a huge literature, a huge evidence base on the political determinants of health, full stop. So on the fact that political decisions impact on the health of populations. That's what I'm talking about today. Much more relevant than that is now the international evidence of the detrimental effect austerity policies have had on mortality rates. And this now comes from a whole number of different studies across a whole number of different populations, and includes this paper published just at the end of last year by my colleague in Glasgow, Jenny McCartney, which, based on some very complex, in-depth statistical analysis, showed that across all high-income countries, wherever some form of austerity has been implemented, it has had a negative impact on mortality rates. But much more relevant even than that is, I think, the wealth of the evidence that has come from within the UK of the impact of the particular form of austerity, with that particular pernicious focus on the income of the poorest and the most vulnerable. And this impact, I think, you see along well understood causal pathways in terms of, first of all, increasing levels of poverty. And you can see that from particular poverty statistics, but also from a whole number of studies showing an association between austerity and increasing numbers of food banks, for example, between austerity and increasing levels of homelessness, for example, between austerity and the negative impacts on mental health, including the mental health of particularly affected populations. And as I said earlier, there's clear evidence links between poor mental health and poor physical health. How that has trickled through to affect mortality at different age groups. These are a couple of studies looking at older age mortality, but also for different causes. A study looking at the association between austerity and drug-related deaths across all of Britain, ultimately filtering through to changes in overall life expectancy, both in terms of Scotland and in terms of England, and indeed the rest of the UK. And actually last year we completed quite a big bit of work, which was basically a critical assessment of all that evidence and lots more. And this showed, I think, pretty clearly that the main drivers of these pretty much unprecedented changes to mortality rates and these widening of inequalities have been UK government austerity measures. Again, just as a quick aside, in a dramatic digression from our usual activities of writing reports like this that nobody reads, we also produced a 3-minute animation with a company called Media Co-op, which is basically a kind of more accessible summary of that same evidence. I'm never one for blowing my own trumpet. I don't do social media or these things, but I would say that I think it's great, the animation, and if you want to have a look at it and even better share it, that would be great. But the point, obviously, from all of this is that in terms of these incredible changes we've seen, it's all been about politics. And before I go on to the fourth and final case study, I just want to very, very quickly go back to one of those charts just to hammer home the point. The data I showed you were up to about 2019. And if we include the couple of kind of peak COVID years, I just want to kind of show you this. So this is the one I showed, which was for premature mortality for females in Glasgow, with this dramatic reversal of previously declining mortality rates among the most deprived 20% of areas. So if we add in the 2 COVID years, then what you expect to see is what you see, an extension of these worsening trends. But the point I want to make here is that if you go back a decade or so, then in Glasgow, a city renowned for poor health and high mortality rates, what you had was a relative success story in the sense that mortality rates were coming down, but they were coming down more sharply among more deprived areas. So we actually had a narrowing of inequalities. Fast forward a decade and a decade of austerity, and mortality rates in these more deprived areas are now higher than they were 20 years ago. It's absolutely astonishing, I think. And it's not only Scotland that this is happening. As I said, this is basically UK-wide. Okay, I did mention this got depressing, and it's now going to get even more depressing. So the fourth and final case study that I want to romp through at the same ridiculous high speed is about the really important issue of drug-related deaths in Scotland. And I make no apology for showing this photograph, because this is the reality of poverty and associated drug use in this city. And this has now reached an international audience, as you can see, because this was actually featured in the New York Times, actually on the front page of the New York Times just a few years ago. And the New York Times also showed that at that time, big increases in drug-related deaths in Scotland had taken us to the unwanted position of being top of the league table for causes for deaths from this cause. And we did some work a couple of years ago which showed that not just in Scotland, but across all of the UK or all of Britain, there were particular birth cohorts, particular groups of people born at certain times that were at much higher risk of early death from this cause. So people born in the 60s and 70s, this is England and Wales, had much higher death rates than people born in other periods. So this is common across Britain, but the thing is that in Scotland, it's all on a completely different scale. But what's really important to understand here is that we know why. It's not a mystery. So there's lots of factors that contribute to this. So it is partly about these vulnerable cohorts who are now aging and experiencing multiple conditions as they do so. A lot of them still use drugs, and it's also about the affordability, the availability, and the types of drugs that are on the marketplace. But it's also, to go back to the last case study, about the effects of those same austerity policies. So if, as I have done, you speak to people working in addiction services in Glasgow, what they will tell you is that if you have a group of vulnerable people with addiction issues, and you either reduce their income through cuts to social security, or you take their income away completely through sanctions, then in their words, not my words, in their words, what they do is they seek oblivion. And if you look at some of the data, there are horrendous examples of precisely that, people seeking oblivion. This is males in Glasgow. The red line is people living in the most deprived 20% of areas in Glasgow. And if you look within a year or two of austerity coming in, people saw oblivion in a truly horrific fashion. As important as knowing what's caused this, we also know what to do about it. And that's because there was a cross-party inquiry in the UK Parliament, which heard evidence from all the experts in this area, and they came up with a set of recommendations which those same experts would agree were the most appropriate recommendations to make. Now, there were multiple, and I won't go into all the detail, but they included things like declaring the issue a public health emergency, reversing those austerity policies which were impacting the vulnerable groups, adopting a public health, not a criminal justice approach to it all, adopting an evidence-based approach, which you wouldn't think was arguable, introducing safe consumption facilities for addicts, and decriminalising drugs for personal use. But the problem is that for the majority of these issues, the powers lie not with the Scottish Parliament, but with the UK Parliament, the UK government. And as you know, the UK government has been led by a number of truly inspiring figures in recent times. And when this report came out, it was the man who's just resigned as an MP who was in charge. I don't know if anybody saw the cover of Private Eye this week, but they were very, very sad to see him go, as you can see there. And the response from the UK government to these really important recommendations was to say no, 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 nope, no, and no. So they even said no to adopting an evidence-based approach, which I think tells you all you need to know about the UK government. So there's a problem, and the problem, as this argument of mine goes, is that it's entirely political. Now, at this point, you are getting quite depressed, and you're probably thinking, shows the funny picture because this is all a bit grim. So I will kind of get to that in a second, but I just want to spend just a few minutes pulling this together in the sense of summarising it and also saying what do we do about it all. So health in Scotland, but also importantly the rest of the UK, is characterised by very wide health inequalities. These are caused obviously by wide socioeconomic inequalities. They're the fundamental drivers of health inequalities and have been caused by decades of government social and economic policy. So they're entirely political, and so the responses obviously also have to be entirely political. In England, and I'll emphasise the word theoretically, in England, this is theoretically easy to do. And what I mean by that is that it's not a mystery what works to reduce inequalities. We know what policy measures are effective. So, for example, there was a review published 10 years ago now in Scotland, which was a review of all the international evidence about what works and what doesn't work to reduce health inequalities. But there have been other reviews and there have been other summaries in other journal papers and reports. We know what measures are effective. I won't go into the detail of what's in that report, but the most important one is obviously about addressing those fundamental socioeconomic drivers of health inequalities. So making society more socioeconomically equal, which would have an impact, a knock-on effect in narrowing health inequalities. So we know what works, but what is required is obviously political will. At the moment, that doesn't exist in the UK government, and the extent to which it might exist in a future Labour government, I think you'd have to be a little bit questionable at the moment in terms of the lack of policy promises from them at the moment, but maybe time will tell. In Scotland and the other devolved nations, it's much more complicated because there's a whole issue of actually whether the Scottish Parliament or the Welsh Assembly or whatever has the relevant economic powers to actually narrow health inequalities. In Scotland, the government talks a very good game about the need to narrow inequalities. Whether they have the ability to do so is, as I say, questionable. But that's a whole other and frankly less interesting presentation, so I'll leave it there. So, as I said, I try and finish on a slightly lighter note. I always do this because the stuff we're talking about is quite grim and quite depressing, and you know, everybody wants to not be depressed. So very quickly, I've got one quick picture to finish on a lighter note, and it does link to the last case study about drugs, not to downplay the importance of that. But this is just something relating to drugs and alcohol services. So what I'm going to show you is a picture, but what's really funny about it is not so much the picture, but the story around it. Okay, so I'm going to show you the picture of a bag that was produced for an NHS conference for people working in drug and alcohol services. And what's funny about it is if you've worked in the NHS or anywhere with a lot of bureaucracy, you'll know how many meetings would be involved, how many people would be involved. So to get a bag for a conference, they would have put out a tender, people would have bid, they'd have put forward designs, that would have gone to a committee, that would have gone to another committee. And along all these committees and meetings and groups, when people approved this, nobody ever thought to think, do you know, is that the right message? I'm not entirely sure. Anyway, it makes me laugh, even if you're not laughing, because I can't see if anybody's laughing or not. So I'll stop there. At the bottom of that screen is my email address. If you have any questions or queries that we don't cover in the next 20 minutes or so, feel free to get in touch. And I hope that was useful to you. Thanks.